Hello everyone, and welcome to another PEDro World-Wide Journal Club. Today we'll be discussing a trial investigating pulmonary rehabilitation programs for people with chronic respiratory diseases delivered as centre-based care compared to telerehabilitation with video conferencing, published by Associate Professor Narelle Cox and colleagues in Thorax in 2022. This trial was also recently awarded by PEDro as one of the top 5 trials in the last 5 years. So congratulations. Today we have 3 panel members, the lead author of the trial, a participant in the trial who is also a community advisory group member, a pulmonary rehabilitation physio clinician researcher, and then myself to moderate the journal club. So let's start by having each member introduce themselves. Please tell us your name, your role, and your affiliation.
Thanks very much. So I'm Associate Professor Narelle Cox, and I'm one of the research fellows in the respiratory research at Alfred Group at Monash University in Melbourne. And what was I? I was the lead author on the paper, and I was the trial coordinator throughout the telerehabilitation trial.
My name is Brenda, and I'm the community advisor with the group membership, and I'm also a participant due to my having a lung condition since teenagehood.
And hi, I'm Dr. Renae McNamara. I'm a clinical specialist physiotherapist in pulmonary rehabilitation and a clinician researcher, and I work in Prince of Wales Hospital in Sydney, Australia.
And then I'm Tiffany Dwyer. I'm from Sydney University and RPA Hospital, where I'm a lecturer in cardiopulmonary. And although I have done a lot of exercise, I've never worked in pulmonary rehabilitation, which is why I'm asking the questions and not answering anything today. So the first questions are for Narelle. Can you briefly tell us what led you to doing this study and why did you think this was an important research question to address?
Thanks very much, Tiff. So for many of the people listening to this recording, we are well aware that pulmonary rehabilitation is a very effective intervention for people that have chronic respiratory disease. However, there are lots of challenges that people experience in trying to access programs which are typically run at either a hospital outpatient department or some kind of centre, so people have to travel to get to them. And there's previously been quite a bit of work that's identified that pulmonary rehabilitation can be effectively and successfully delivered to patients in their own home. However, one of the key things that had often not been looked at in those trials was the nature of the supervision. So often the supervision was either asynchronous or there was limited supervision of exercise training. And so the two sort of underpinning factors for this particular model of rehabilitation that we were trialling here was that we wanted to see what would happen in a model where we were able to provide real-time supervision of exercise training, but where we were also able to prescribe exercise training where we could quantify the intensity of training and monitor in order to be able to progress that throughout the trial, whilst delivering a model that would hopefully overcome some of the challenges and barriers that people face trying to access centre-based programs.
Okay, and can you briefly explain the study design? For example, why was it appropriate to be an equivalence trial?
So as you said, it was a randomised controlled equivalence trial. So that meant the participants that agreed to be in the trial were randomly allocated to one of the 2 interventions, so either centre-based rehabilitation or the telerehabilitation comparison. But the main reason it was an equivalence trial is that we wanted to see whether this new model was as good as the model that we already know exists and works. So we weren't trying to replace one model with another. We were looking to say, could this new model do the same as what already exists and that we know works, and in that way be able to provide more opportunities for people to be able to do pulmonary rehabilitation, not less opportunities.
Okay, and can you briefly describe the 2 interventions?
Yep. So both groups comprised an 8-week pulmonary rehabilitation program with supervised exercise training that was individually prescribed and progressed, as well as personalised education based on what the participants required. Both groups undertook around 30 minutes of aerobic training in every session, and they were prescribed functional upper limb and lower limb strength training exercises. It was individually prescribed for each patient and progressed over each week. The only difference between the exercise training setup, if you like, between the 2 groups was that one group undertook their exercise training in a supervised environment in the centre or the hospital. And then the comparison group, the telerehabilitation group, their exercise training, still 2 sessions a week in a group setting, was undertaken from their own home. So no one had to travel anywhere, and they were supervised remotely via video conferencing. So just like we're talking to each other now on a screen.
Okay. And the telerehabilitation group had an initial home visit for the first training session, then virtual sessions with up to 6 participants in each session, and centre-based group had 8 to 12 in each session. So, Renae, as an experienced clinician, how do these interventions that Narelle's been describing compare to what you typically deliver or see in clinical practice?
Thanks. Yeah, in a standard centre-based pulmonary rehab program, patients will typically receive this structured supervised exercise training program that consists of the aerobic and resistance training, as well as education on topics like disease management, breathing techniques, nutrition, medication, as well as psychological support or behavioural interventions to improve their self-management and their mental well-being, as well as social support from interacting with others in a similar condition. So these programs are typically delivered 2 to 3 times a week over a course of 8 weeks. So the centre-based pulmonary rehab program delivered in this study imitated real-world clinical practice. We know that telerehabilitation is an emerging model that uses this technology of video conferencing and virtual platforms to deliver the rehab remotely, and that patients participate in these exercise and education sessions from the comfort of their own home. Certainly, the tele-rehab program delivered in this study matched the core exercise training components of the aerobics and resistance training that we want to deliver in terms of frequency, duration, intensity. So it was very similar or matched to the centre-based pulmonary rehab program. And this is very typical of the clinical practice where tele-rehab is delivered using video conferencing softwares in these virtual real-time group settings.
Okay, now let's hear about the participants in the trial and how they found things. So, Brenda, first off, what was your motivation to participate in a rehabilitation study?
I think other than doing other exercise that I've been doing, like physio and swimming, I just wanted to also experience a different pathway to antibiotics because that seemed to be the fallback all the time when you have an exacerbation. So I didn't need to leave home or to travel. It was an efficient exercise, which I could factor into my day. It didn't take all day to accomplish. And also, I just felt that if it enhanced the distance between exacerbations, I could perhaps continue that afterwards, after the program had finished. Plus, it was a sense of challenging myself, I guess. And I always like to do that.
Good on you. And so you already said one of the benefits of telerehabilitation was the fact that you could do it at home. What, before the trial and knowing that you could do it at home, what else was your understanding of what telerehabilitation would involve?
Not that I had a real understanding of what it involved to the degree that it did involve, but perhaps on your phone you would do exercises or on YouTube, but you didn't have the sense of support from that. So that never lasted too long. My motivation dropped off from those other examples. So to do this, I think that was a memorable experience for me. And to continue until COVID hit, and then afterwards to remember the benefits of what I had done, then has continued to this day, really. So I continue to join a gym and do other things as well to seek community support, not be isolated.
That's brilliant. So when you were saying you found the support helpful, was that support from the clinician or the support from the others with whom you were exercising online as a group?
Mainly from the clinician, but also having a discussion with others, learning their story, their isolation as well. Lung disease is something that other people don't really see and sometimes can't factor in your experience unless you're ill every day of the week type of thing. So it is an isolating disease, really, if it's chronic and long-term. So others had experienced that as well, that family didn't understand their issue. But certainly the clinician, you wanted to be motivated to challenge yourself because the clinician themselves were putting the resources in place for you, you noticed that there was a change. Pulmonary care doesn't seem to have a lot of advertising or support or funding or change in our conditions. So anything that comes my way, I'm happy to be included in it.
That's great. And was there anything that you found made it easy or difficult to complete the exercise training online?
No, not really. No, I can't think of anything. Nothing pops up. No.
Yeah. I guess one thing maybe you talked about the support. So when you try to do things on your own, it was really hard to keep going. So perhaps that was something that helped make it easy, and having it in your home was always a good one as well. So adherence with the 8 weeks of pulmonary rehabilitation was very high in this study, defined as completing at least 70% of the 16 sessions. And the adherence rates were really high. There was 83% for the telerehabilitation group and 76% for the centre-based group. So Renae, how do those completion rates compare to what's typically seen in clinical practice?
Yes, certainly the completion rate for the centre-based pulmonary rehab group in this study was quite high compared to what's often seen in clinical practice. In most clinical settings, I think adherence to face-to-face supervised centre-based rehab programs is generally much lower, with completion rates often ranging somewhere between about 50% and 75%. So 76 was, above what we would typically see. However, we know that tele-rehab programs typically show improved adherence rates when compared to the centre-based programs, because that virtual delivery mode removes the logistical barriers such as travelling and scheduling, which often contributes to the lower adherence rates that we see in the centre-based settings. So I was certainly not surprised by the high adherence that the study achieved with the tele-rehab program. That was a great outcome and really demonstrating what we see in clinical practice.
Interesting. And Narelle, why do you think the rates were so high?
I think Renae's largely answered my question there for me, but I think obviously, as Renae indicated, one of the key factors for the tele-rehab group is, of course, that the program was delivered to them in their home. So as Renae said, we've taken away the need to travel. As Brenda said, it meant you didn't have to invest the whole day to be able to do your rehab. You could slot it in with your schedule. And as Renae's alluded to, we've now got increasing evidence that programs that are delivered to people in their homes have a much higher likelihood of people being able to achieve program completion. I think in this instance, for the centre-based rehabilitation participants, I think that the relatively high completion rate is probably likely a factor that's associated with the engagement and support that people receive by very virtue of the fact that they were in a clinical trial. And obviously that's not suggesting that they don't get engagement and support when they're attending, a regular outpatient program. But I think that we know that there is, again, plenty of evidence that tells us that when people are involved in trials, there is additional support and engagement that comes with those things. So to be fair, that's possibly part of it, I think. And we'll touch on this a little bit later, but I think a nice thing about this particular trial is that when we have rolled it out into clinical practice, we're still getting completion rates in the tele-rehabilitation group around that 75-76%. So it's still able to be reasonably high.
Yeah, that's fantastic. So talking now about we've gone through the design and then the interventions and the participant experience, and now looking at outcomes and results. So with the trial, we had measures taken at baseline, at the end of 8 weeks of pulmonary rehabilitation, and a 12-month follow-up, with the primary outcome being change in dyspnea measured on the CRDQ from baseline to end of rehab. And there were several secondary outcomes, including health-related quality of life, exercise capacity, and annual hospitalisation. Out of interest, Narelle, why did you choose dyspnea as a primary outcome?
So one of the main reasons that the dyspnea domain for the CRQ was chosen as the primary outcome is that it's responsive to change pre and post pulmonary rehabilitation in people with a variety of different chronic respiratory diseases. And I guess that's perhaps worth flagging here as well, in that the recruitment population in this trial represents all those people that are referred to pulmonary rehabilitation. It wasn't just limited to one particular chronic respiratory disease diagnosis. But not only is the CRQ dyspnea domain responsive to pulmonary rehabilitation, but importantly, change to dyspnea is an outcome that is both meaningful but particularly important to patients. So we wanted to pick an outcome that meant something to the people that were enrolling in the program. And I think the other advantage of this particular outcome for our participants is that it's relatively low burden insofar as it requires the completion of a questionnaire, but that creates opportunities that if, for example, someone wasn't able to travel to be able to complete that outcome in person, there were other opportunities for us to be able to collect that outcome with people that were less taxing.
Now, I know the trial was a while ago, Brenda. You've talked about the reasons what motivated you to do the participation in the study. And since then, you've continued to have this lifelong exercise. Do you remember back to when you were in the study? What did you get from doing the rehabilitation program?
Well, physically, I felt in better shape. I remember losing weight and had better breathing, and I didn't need to use the puffer as often. And I found that my walking improved in the distances I could travel. And around Eltham, that's pretty hard. So
is that a hilly spot or something?
I felt a great. That's right. So it was beneficial that way, and I think it motivated me to keep up some form of exercise afterwards, and to continue to do as much as I could in the working day, at least. Yeah.
That's brilliant. So obviously you've continued to keep working on these things. Did you notice how long the effects lasted, or do you still have those benefits multiple years down the track?
Well, COVID interrupted, but I tried to keep walking every day. I just think mentally I understood that it was important to exercise after having done the tele rehab, because I noticed such a difference within myself, and I noticed I needed outside support in not being isolated at home myself. So to reach out to the community when needed, and to continue with a walking group. And so I did that, and I'm still doing that. And I now go to the local gym. So I think just realising the importance and the benefits of exercise from the tele rehab keeps prompting me to stay within that type of exercise. Aerobic exercise is very important for a pulmonary condition. And once you realise that, I think you've got to take it on board.
Excellent. So there's lots of benefits and experiences that Brenda's just discussed there. Narelle, were there any other common themes or responses identified by participants in the qualitative components of the study?
Yeah, so I mean, Brenda's given a really nice synopsis there. The people that were part of the tele-rehab study, we conducted interviews with as well to find out about their experiences of it. And across the board, people told us that being able to do rehab in their home actually made it easier for them to do rehab. And one of the sites in this particular trial was located in rural Victoria, in Western Victoria, about 400 kilometres from where I'm based here in Melbourne. And there were a number of people in the trial from that particular site that then still lived another 100, 150 kilometres further away from the centre where rehab was taking place. And I remember some of those people in particular saying to us, they agreed to be in the trial because the opportunity, having that 50% chance that they might get to do rehab from their home, actually made it a worthwhile opportunity for them. And these were people that had knocked back offers for rehab over the consecutive, not just occasions, but years, because it was too hard for them to get to. So that concept of rehab coming to you rather than you going to rehab made life much easier for people. Brenda's already highlighted the support aspect that came from being in a virtual group. And I think for us as clinicians and researchers, that was a really nice thing to hear, because one of our concerns when we started the trial was that by asking people to stay at home to exercise, maybe we were cutting them off from the concept of being in a group of people. But actually what our participants told us was that they did get support from the clinicians that were on the other side of the screen. But like Brenda said, they got support from the other people that were online. They felt like they were part of a group, and they valued the fact that they got to see and speak to people that understood what they were going through and had similar experiences to them. And what some of the people that we've spoken to have also said, and Brenda alluded to this as well, in terms of, recognizing that isolation wasn't working for her and that she needed to get out, is that yes, as clinicians, we often, I think, focus on the physical benefits people get out of rehab. But a lot of our participants and patients that have done tele-rehab since then actually talk to us about the benefits that what do they say, that you'll get benefits that you didn't even know to expect. And a lot of that is not feeling so alone. The final thing that people told us when we interviewed them, almost without exception, was that the bike seat on our bikes was really uncomfortable. So again, we tried many strategies to be able to do that. I'm not sure if Brenda remembers the discomfort of those bike seats, but again, making sure that if you're going to have an equipment-based program, making sure that there are ways that you can adapt and address things. Clearly, people were still happy to jump on the system and exercise with us despite the uncomfortable bike seat. But, maybe they're the kinds of things that we need to think about a little bit more laterally to help support people to be able to exercise ongoing, rather than just assuming that that you had a bike once, that you'll keep using a bike.
I used to work in an exercise lab, and the amount of times doing an exercise test, and at the end you'd ask someone, what was the main reason why you finished? Then they would say the bike seat was uncomfortable, and I'd be like tearing my hair out. So I completely relate to the issues with the bike seat.
We did try lots of different things, and there's no one good fix. So if there's anyone out there that has an in with a bike seat manufacturer, maybe that's what we need to entertain.
That could be the ongoing research from this.
Yep.
So Renae, as an experienced clinician researcher in this field, what do you think are the key clinical implications from this study?
I think the bottom line is that tele-rehab is an effective alternative to centre-based rehab for people with chronic respiratory disease, especially for those who face challenges accessing face-to-face programs. And that might be due to geographical reasons, logistical reasons, or even health-related limitations. I think the results from this study are really going to make pulmonary rehab more accessible to a wider range of patients, particularly those living in rural, remote areas, underserved areas where there's no programs available, who don't have that access to a face-to-face program.
Now, one of the most difficult things in pulmonary rehab is to help people maintain long-term benefits in exercise capacity and quality of life after finishing a pulmonary rehab program. I noticed in this study that the tele-rehab group maintained their 6-minute walk distance up to 12 months after finishing pulmonary rehab, but the centre-based care group returned to their baseline or pre-pulmonary rehab levels. One of the initial hopes or theories with home-based or tele-rehab care was that it may increase exercise independence as people may be more used to exercising at home. We've already heard from Brenda how she continued her exercise journey. But I noticed that in this study, all exercise equipment was removed at the end of the 8 weeks of training. So Narelle, apart from Brenda being amazing and going and joining a gym and continuing, why do you think on the whole, the tele-rehab group were able to maintain their exercise capacity for at least a year?
In truth, I really don't know. And I really wish that I knew the answer. As you said, we provided all of the equipment into the home just for the 8-week duration of the tele-rehab program, and then we took it away again. And actually, when we talked to our participants, a number of them said they actually felt kind of sad when we took it away, because I guess they saw it, they had a prompt, they were happy to exercise during their 8-week program, but we took that away. Anecdotally, I can tell you that there were some participants who by the end of their 8 weeks said, actually, I now would like to purchase a bike for myself. But, I would suggest that at best that was not more than 10% of all of the people in that group. So I guess what we can't say is, we absolutely can't say, well, it was exercise training on a bike that is the thing that kept people going, because their maintenance of gains were across both cycle endurance training and walking distance. So, there's clearly something going on. It didn't play out in terms of physical activity participation. So there was no difference in the groups, and there was also no change in response to rehabilitation in terms of the amount of physical activity that people were doing. So exactly what is the reason behind tele-rehab translating into those longer term outcomes? I really hope that we might be able to tease out some of the answer to that. I think it's going to be both more nuanced and more complicated than just saying it was about the physiology of the training that people undertook, because we did effectively take that training stimulus away.
Now, Brenda, you've already told us some of these answers. How did you find being able to keep exercising after the tele-rehab program had finished?
Well, I think because the tele-rehab was such a positive experience for me, that I just made it what I needed to do. I knew that I needed to continue because what really is the alternative? You can't just sit all the time when you've got a lung condition. You need to move. And I think that message was sent home to me quite clearly. So I think that I can understand people I don't want to go off topic, but I think if people in the regions, they haven't had access to a gym or anything at all. And so it becomes a mindset that you can't do it. It's impossible to do. It becomes too hard. And so when you have a bit of a bright light in something like the tele-rehab, you grab it, but then it would be easy to fall back into what's been many years of nothing, a desert for them. So I think it would be mentally difficult then to change your view of the world when for years you've had nothing to grab onto to help your lung condition. Whereas around the suburbs, etc., you've got multi-choices of something that you might like to do that's physically enabling. So choice and resources are what's needed out there in the regions. So yes, I mean, I've done Keyser, I've done the local gym. I've supported myself with a walking group, so I'm not isolated. You can talk while you're walking 6Ks, and you don't realise you've walked 6Ks because you've been chatting away. And then you have your coffee. So again, it's all fairly positive. Very fortunate, I find. Yeah. So.
That's great and very motivating to hear. Renae, do you have any other suggestions on how to help people maintain their exercise capacity after they've finished a pulmonary rehab program?
Yeah, I think Brenda stole my thunder there with these examples that I'm going to give. But I have a few suggestions. I think, firstly, it's really important that we develop a personalised home exercise plan for patients, and that should be based on the exercises that they perform during their rehab program. We know that that's the most important thing that should be done, and that plan should include a variety of exercises, such as walking and cycling and strength training. They need to be feasible. They need to be able to be done in the home, potentially without any exercise equipment, without any cost because cost can be a big barrier. For example, joining a local gym, that's not feasible for everybody. They may not be available, they may not be affordable. But it's also important for adherents to tailor it to the individual's abilities, also their goals, and also their preferences. So I think the exercise options can include individuals' likes. So potentially you might look at something like swimming or water-based exercise if that's their cup of tea, or other exercises that make them huff and puff. Maybe they love a line dancing class, or they want to give a gentle Zumba class a go. So I think variety of exercise is really important because it can certainly help prevent boredom. And of course, the exercise program and schedule should always be realistic so that they can maintain the consistency. So things like setting reminders, setting alarms, adding it to your calendar, putting in a regular day and time that you set to that schedule, incorporating the exercises into your daily routines is really important. I think secondly, as Brenda mentioned, connecting with other people who have similar experiences is also really important. So encouraging people to exercise with a social network or with a support group can also help them maintain their motivation and also foster that sense of accountability. I need to show up because I've made this day and this time to meet them. And if I don't show up, someone's going to call me and check in on me and see why I didn't arrive. So I think a great example of this that Brenda gave, and something that we certainly use, is the weekly walking group in the local community. And that could be walking around the park, it could be walking along the water foreshore, and following that up with that social morning tea that Brenda also mentioned is so important. It's really important. Got to have that cup of tea afterwards. And I think finally, helping people set achievable short-term goals that are quite meaningful to them, such as potentially the distance they've walked or the time that they spend exercising is really beneficial. And then it's really important that we celebrate those milestones, such as now they can walk 2 laps of the shopping centre, because that can help them maintain their motivation as well. So I think there's a few things around the home exercise plan, connecting with others and social exercise, and short-term goals and celebrating milestones.
Great stuff. Now, Renae, in your opinion, which types of patients with chronic respiratory disease are suitable for telerehab? And are there instances where you would recommend centre-based care instead of telerehab for people with respiratory diseases?
Yeah, look, telerehab is still a really growing area of interest and research. And I think the great thing about this study was it gave us concrete evidence for people with not just one single respiratory disease, but a variety of chronic respiratory diseases. Although much of the other research in telerehabilitation in pulmonary rehab has been in people with COPD. However, we know from previous work in COPD and rehabilitation that other chronic respiratory diseases such as asthma or bronchiectasis will typically achieve similar benefits. However, telerehab is not suitable for all people referred to pulmonary rehab. So, for example, people with cognitive decline or severe mental health issues, they may struggle to engage with a telerehab program because it does require a certain level of understanding of the technology and adherence to exercises. So that could be a barrier for these individuals. However, we've certainly had some success in some cases because you can use family members, you can use carers and support people who can assist with that technology side of things. I think other health issues such as poor hearing, poor eyesight, or a history of falls and balance issues may also mean that telerehab might not be the safest option for their rehab program. So it's really important at this point that we undertake a face-to-face assessment initially with a health professional, because then we can determine whether telerehab is the most safest or most effective or most feasible method of rehab, or is there another mode of delivery that we should offer to each individual. There's certainly a method for everybody or a mode for everybody. It's just determining which one's the most safe and most effective.
Now, this study had quite fancy equipment, to be frank. How feasible do you think it would be to implement this model of telerehab, or what resources would you need to get it off the ground if you were to offer it in your service, Renae?
Yeah, look, telerehab by video conferencing is certainly a feasible method to deliver our pulmonary rehab programs. And we certainly saw this during the COVID-19 pandemic when pulmonary rehab programs across the world had to really rapidly transition from delivering face-to-face programs, which were now going to be putting our patients at risk, to a telerehab method. The method that was used in this study required the internet. So that's a big factor. If you don't have the internet, unfortunately, it can't be delivered. You also need a video conferencing platform, and there are so many free versions and also dedicated healthcare platforms that are available. So I don't think that that's a barrier any longer. We certainly need some monitoring tools such as a pulse oximeter, having access to the Borg dyspnea scale. It's important for the exercise training. And exercise equipment of some sort is required, and that can range from the fancy exercise bikes that are delivered to a patient's home that obviously would be expensive. Then there's the resource of someone to deliver it. But we can also move to the freely available equipment that we have in our household, the items that we get from the kitchen pantry, the things that we can get from the bathroom cupboard like shampoo and conditioner bottles that we can use as hand dumbbells, things like a sturdy chair that we can use for exercises as well. So we can go a high cost model or we can go a very low cost model, which means that tele-rehab can be feasible in so many different settings, depending on what resources are available to you.
And if I could perhaps just follow up on that point from Renae as well, you are absolutely right. This particular trial and this model did make use of equipment and technology. But one of the things that we made sure of is that all of the pieces of equipment that we used are ones that you could literally walk down the street to the local shops and we bought an exercise bike that was available from effectively a high street store. There was no bespoke equipment.
I think Renae already answered this. I was going to ask you about what barriers there are to delivering centre-based pulmonary rehab and barriers to delivering tele-rehab, but you've kind of answered that already by saying, one barrier is the internet, the video conferencing, but that's no longer a barrier. You identified strategies, just like Narelle said, that this study used just regular equipment. It wasn't bespoke, super duper fancy stuff. And you can modify your training according to what's available. And then we've already discussed quite a lot about the barriers for centre-based care, especially being that travel and having the whole day taken up potentially trying to get to and from. Are there any other barriers that you see, Renae, for delivering centre-based care and delivering tele-rehab?
I think, as you mentioned, the internet access is going to be a barrier, but there are other modes of delivery we can then offer there. I think low digital health literacy is always going to be considered a barrier, and only really a small degree of technological ability is actually required for tele-rehab. It can be taught, and I think what this study showed was if you provide written and visual instructions, and as what we do a lot is teaching family members and carers, we can overcome this. Another barrier I think a lot of other people like to raise is that I don't have enough space at home. But I think with some very clever thinking, I think with a home visit from a health professional, some flexibility of the space that you're going to use. So looking at alternate spaces, alternate exercises, and this can often also be overcome as well. So I think whilst a lot of people will throw up some barriers, I think most of them can actually be overcome.
And if I might just again add to that as well. So as Renae has rightly pointed out, telerehabilitation isn't for everybody. But one of the things that we were conscious to do in this trial is that it was open for all comers. So you didn't have to have a device. You didn't have to have tech skills to be able to do it. It was, our job as the clinicians delivering the intervention to make sure that we set our participants up so that they could do the program properly. And as a consequence of that, as Renae's alluded to, we have resources that are available for anyone that would like to make use of them that can help to fast track that process of supporting someone to be able to, use an iPad, access a video conferencing platform and all of those kinds of things. So again, yes, being able to interpret the instructions and follow them through is absolutely important, but to be able to participate in one of these programs, patients themselves don't actually have to have a wealth of experience. We can support them. I guess if I might, a couple of the other barriers that absolutely exist to delivering tele-rehab are not actually about the patients, they're about the clinicians. And that concept of being able to deliver the technology and use the technology is one of the key barriers that when we talk to clinicians, that they keep coming back with saying things like, well, I'm a physio, I shouldn't have to deal with all the technology type stuff. So the barriers to delivering rehab are many and varied, and they're not always just on the patient side, but they can be on the clinician side as well.
might probably throw in one thing we haven't mentioned is that one of the benefits of telerehab is for like immunocompromised people or like you're not wanting any cross infection. So that can be one benefit that can't be delivered in centre-based care as well. So moving on from that, Narelle's just nicely brought it in. One of the barriers is clinicians and their knowledge about delivering it. What training do you think, Renae, is needed for physios to effectively deliver telerehab?
Yeah, certainly to safely and effectively deliver telerehab, physios will require initial training and some technical proficiency in delivering virtual care and the ability to troubleshoot those technological issues. But to be honest, they're not beyond what we do every day in a workplace where your computer decides it doesn't want to turn on when the internet doesn't want to connect. So they are technological issues that clinicians might raise as a barrier, but they're actually easily overcome. But physiotherapists would require training in remote coaching and monitoring. It's very different, not being face-to-face. And they need to have some advanced communication skills with verbal cueing, demonstrations as well. I think building a rapport without having that physical presence with your patient and being able to educate and coach your patients effectively online are also skills that are required. And we can never forget that training in patient safety and risk management, such as how to respond in an emergency. What do you do if a patient falls? Other things like ensuring privacy and security, protecting the data, ensuring confidentiality, and seeking consent is also an important skill that most physiotherapists, if they haven't worked in telerehabilitation before, will need to be upskilled in.
Now, I think, Narelle, you mentioned that your team have got a website that has lots of resources to help upskill and train physios as well. Can you tell me a little bit about that?
Sure. So our website is www.PEDro and that was born of some work that we undertook with clinicians across a variety of healthcare contexts across a number of different countries to understand what were the challenges for them to be able to implement a program of telerehabilitation in their clinical care. And as Renae's indicated, some of the key challenges that people identified were about feeling comfortable with using the technology and having access to relevant training. And whilst this website obviously doesn't cover everything and doesn't magically mean that you will have every resource at your disposal to be able to deliver telerehab, what we've tried to compile in one location based on the feedback from clinician and our experiences with running the trial is a suite of resources that can be, if you like, as our participants described it, a bit of a one-stop shop that if you were entertaining wanting to start a telerehab program in your service, then we've provided some resources and some direction based on both our trial evidence and our interviews with clinicians across different health services to be able to make a start that you can then adapt those resources to your local context. So there are videos that can be used for showing patients how to use an iPad and access Zoom if that happens to be your program. There are details around the kinds of equipment that we used in this particular model for which there is clearly now evidence to support its use as a model of pulmonary rehab delivery. There are video resources that might be able to be used to help support clinicians in that, if you like, understanding and training of how to deliver this model. So when we spoke to clinicians, one of the things that they said was that having the ability to learn from someone that has delivered telerehab, potentially shadow them if that's at all possible, would be one of the ways that they would like to learn about delivering of telerehab. And whilst in all circumstances and contexts, shadowing someone with experience might not be possible, we've created some video resources that might serve as a starting point. Renae mentioned about the need for thinking about monitoring processes and safety procedures if you're delivering rehabilitation remotely. And so again, there are suggestions and resources on the website that people can use as a starting point. We are not saying that it is the only way to do things, but as a starting point to then consider within your local context how you might need to be able to adapt and change things. And if you like, that's kind of the core element of implementing any of these new evidence-based programs into practice, is to take the core elements that have been proven to work and then adapt things relative to your local context. So, you know, the safety procedures is a good example. We've provided an example of what is appropriate in our context, but in a rural setting or some overseas settings, that exact plan might not be appropriate, but you can use that as a starting point and adapt it for your setting.
Great, and I'll put the web link for that website in the show notes for people to be able to access. So great promotion of a well-designed resource. Thank you. Now, Brenda, you have already mentioned this, but really, what advice would you give to someone who is considering participating in pulmonary rehab or telerehab? You said before, just grab that chance, grab that hope. It's going to do wonders for you. What if someone's kind of unsure, the physio's telling them, I think pulmonary rehab will be good for you, when they're a little bit hesitant or unsure, thinking maybe they're too breathless, they don't think they could do it. What advice would you give to that person?
I try to encourage them to participate and give them my experience. I'd relay that to them, especially if they're isolated. I'd provide some advice on aerobic exercise, how that does help, and that they can start small for a short time. They don't need to do half an hour. They can do 5 minutes or whatever they feel like and build up. We could choose something that is of interest to them, that they would like to participate in, that they find, as Renae was talking, whether it be walking or whatever else. But pulmonary telerehab, I think, telerehab rather, I think it's a community resource for people to be involved, and a positive benefit both physically, mentally and emotionally. We all have a different starting point. We all have a different baseline from which to work for pulmonary rehab. And I think a lot of people have COPD that don't know each other have COPD in their community. And so I think just being part of a group doing that and seeing others doing it and reaping the benefits of it, I would try to encourage them greatly to do it and not give up too easily, because it's something, or just not put barriers in their mind before they've even started, to perhaps give it a go for a couple of weeks and see the benefits and see if they can continue. Because mentally, I think it's part of the problem. We continue to put issues in the way that are not insurmountable. You know, we can get over that. We just have to find a different attitude to approach the work. And a lot of us see it as work.
I think there are some great strategies and tips in there for all clinicians when they're first discussing pulmonary rehab with someone. So thank you for your insights into that, Brenda. Now, Narelle, you've obviously finished the study and it was a while ago, but can you think back, can you comment on the economic or cost analyses from this study?
Yeah, sure. So I think there's two key points that came out of the economic analysis for this particular trial. So the first is that the costs that were associated with delivering centre-based rehabilitation and telerehabilitation, so that's the total costs for 16 sessions over 8 weeks, were only $300 more for telerehab compared to centre-based rehab. And those costs take into account the costs of all of the equipment, the staffing, the infrastructure for both models, but they also take into account the personal time of the patient, the travel, the transport costs, and associated costs if a carer was helping someone to get to and from rehab. So it was a very comprehensive assessment of costs, which boiled down that there was $300 difference between the two models. And I guess I make that point because oftentimes it is said that, well, telerehab is too expensive. Well, it's $300 difference. So yes, there is a difference in the costs, but that $300 is over the entirety of the 8-week program and all of the elements. One of the things that is associated with that I think is a really important thing to mention is that while there was a slight difference in the costs for the two different models, there was a significant difference in the costs which were borne by the patients. And in the case of the centre-based rehabilitation, the vast majority of the costs, and I did the maths on this yesterday, and it works out at 72% of all of the costs associated with delivering delivering centre-based rehabilitation are actually borne by the patient. Okay. By contrast, 74% of the costs associated with delivering telerehab are borne by the health system. So that just sort of highlights further complexities, if you like, in terms of those barriers for people to being able to access care. I think we typically think of centre-based rehabilitation in an Australian healthcare context as being a free healthcare intervention that people are receiving. But we fail to take into account the costs that are borne by the patients in order to actually get there and get away from the program. The other key point that comes out of the economic analysis is that completing a program of pulmonary rehabilitation is the key to the cost benefit for the health system. And what this study has confirmed, which is similar to previous research, is that it actually does not matter which model of rehab you undertake, if it's at the centre, if it's tele-rehab with video conferencing and equipment, or if it's tele-rehab with delivered via the telephone and less equipment. The important part is meeting the threshold for completion. So as you said, in this case, it was doing 70%, doing enough of the program to get benefit from it. And what we found in the economic analysis for this study is that if you were a rehab completer, irrespective of where you did that program, then completing rehab was associated with saving the health system nearly $20,000 per person in the year after they'd done rehab. And that was primarily due to reductions in hospital admissions and emergency department presentations. So I think what this tells us is that the benefits for rehab beyond the physical, emotional, and mental health benefits for patients, but the benefits for the health system are there if we support people to be able to do rehab in whatever location it is that works for them.
And can you talk about the results from the implementation study on this model of telerehabilitation with video conferencing?
So this we were able to implement this model of telerehabilitation into the clinical practice located where I work here in Melbourne. Now, it's worth pointing out that, of course, we finished this trial. We collected the last data for this trial in May of 2020. So we were right on the precipice, as it were, of COVID, which, as Renae's alluded to, did, if you like, fast track the need for remotely delivered rehabilitation to become a much higher priority for everybody. So, you know, I absolutely acknowledge that the circumstances of the world at that point in time probably made the clinical rollout of this model of rehabilitation happen quicker than it might otherwise have. We conducted an evaluation in our clinical service over 3 years, and during that time, of all the people that started rehab, around 16% of them undertook the telerehabilitation program. And that, in some circles, sometimes I feel like that's not a very high number, but it also reflects the fact that, as we've said already, there is no one model of rehabilitation for everybody, and telerehabilitation is also not for everybody. So that 16% reflects that it suits some people, it doesn't suit other people. There's some other factors that tie in with that. So when it came to rolling out the program in our clinical service, we had to make some changes from the clinical trial. In the trial, we provided mobile data for everyone to be able to access the internet to be able to do the video conferencing, and we weren't able to do that in our clinical service. So to be able, in our clinical evaluation of this model, for someone to be able to do telerehab, they had to have their own Wi-Fi at home. So as we've already discussed, that automatically takes some people out of the picture. I think another, if you like, adaptation in the trial, we provided all of the equipment, and in our clinical service, we again have access to exercise equipment and an iPad that people can use for the 8 weeks of the program. But also we had around 40% of the people that were part of this clinical evaluation provided some degree of the equipment themselves. So that might be that they had a device on which to access the video conferencing software, or they already had exercise equipment in their home that they were going to make use of. So it just sort of demonstrates to us that, again, we can stick to the core principles of rehab. We can individually prescribe a program. It can be progressed according to a standard protocol, but we can make some tweaks and adaptations to the exact nature in the way it's delivered. We highlighted before that, again, pleasingly, of the people that have done tele-rehab in our clinical service, 75% of them were able to complete the program. So we've already flagged that, you know, completing that rehab at home increases the likelihood that someone will be a completer versus when they have to turn up for a centre-based program. But so again, while having this advanced technology model and getting it into clinical practice was probably helped by the pandemic environment that we found ourselves in at that time, I think one of the challenges that we still face is being able to grow the availability of these evidence-based models and to be able to maintain their delivery in light of the challenges that clinicians and health services face with respect to availability of resources and infrastructure, ongoing preferences for face-to-face delivery of care, and that's both at a clinician level but also at a patient level. And I think some of the uptake of our model in clinical practice, if you like, perhaps was lower than I might have thought it was. But again, when we came out of COVID, and of course we were based here in Melbourne where lockdowns were quite extensive, I think people were looking for opportunities then to actually get out and away from the house. So that sort of might have played into that as well. But for these, you know, models to be available for patients, we have to, again, and I'm reiterating points that we've already made here, but we have to be able to work with clinicians and health services to be able to make sure that they've got the resources, they've got the infrastructure, they've got the training and the mentoring to enable more models of rehab to be available for patients to choose what works best for them.
Now, you've done quite a suite of studies looking into telerehabilitation for people with chronic lung diseases. What do you think would be important future research projects from this body of work?
There's always lots. I think that one of the key things is going to be exactly how do we nail that concept of supporting more locations to have this as an option for their patients, and particularly targeting areas where access to centre-based rehabilitation is challenging. So by that, I think I'm largely leaning us towards rural and remote areas of practice. I think it would be ideal if we could work out why it was that in this particular study, our tele-rehab patients were able to maintain their rehab goals over time. But as we've said, again, numerous times, the model that we've built here doesn't work for everybody. And as we've also highlighted, there were costs involved with it because it was relatively equipment and technology heavy. So I think looking at ways that we can not only support clinicians and health services more broadly in the adoption and rollout of evidence-based rehab programs that may make use of remote delivery, but how do we further adapt these remote models that have real-time supervision that might require fewer pieces of equipment? And I think one of the things that as clinicians we find really challenging, as we've got more and more models of rehabilitation available to us that our patients can choose from, is helping to support patients to either be directed towards a model that is more suitable for them or to help them choose the right model for them. So that concept of which model for which person is something that I think remains a challenge for us. And if we can have a few more signposts along the way, then that might make life easier for both clinicians and for patients.
Now, I think the final word needs to go to Brenda. Narelle said what she's thinking to do in research in the future. What do you think is an important topic for future studies on pulmonary rehabilitation for people with chronic respiratory diseases?
I think there's just so little available at the moment that I think the tele-rehab pulmonary program was a light in the darkness for people. So for that to continue, especially to regional areas, and for people to know they're not alone, for a group, for others to get together who have the same condition. They probably don't know of each other because it seems to be a silent disease in a way. So I think more advertising that we're available, that we can do things, that each hospital has this program.
Thank you. I think that's a good place to finish. So thank you very much for the panel today. Thank you, Narelle, Brenda and Renae. I think this has been a really interesting discussion.